I think it's been about 10 minutes. Does anybody need more time? Everyone's good. Okay, about 1 more minute, and then we'll get started with class. Okay, so we can go ahead and get started and start talking about a couple things. First, I want to kind of just talk about a little bit of my goals and plan for our time together today, and then we'll give you some time to kind of talk in your groups about the case, and then we'll go from there. Okay? All right, so on Friday, you guys all got your pens, and you're getting ready now to make the transition, right, out of the classroom and getting ready to start APPEs. So my main goal for you today is to sort of go through this patient very similar to how my fourth year students go through these patients when they start APPE rotations, and kind of talk about sort of how we work things up. I know that you guys have been doing that this whole semester, and from what I understand, since I only teach in this class once, is that sometimes depending on the practice setting that your patient is in, or who the faculty member is, you may have like a little bit of a different twist on each of the patients. So I will do my best to follow the structure and the format that you guys have been following all semester, but I'm also going to really stress and emphasize how we do this inpatient, how we present patients, how we work them up, and kind of how we go through their different problems and make those assessments, and sort of how we communicate with each other. So hopefully you guys after the class today will kind of have a glimpse into what it is like to work at patients, present patients, and how we interact with the healthcare team starting in our APPE setting. So we will, that will be our main goal for today. The other thing that I also want to emphasize is if you guys have questions about things like abbreviations, or, I mean, as we kind of talk about this anytime that I teach, but especially now, if you have questions about how to look at the patient, how to work them up, or something doesn't feel quite right, like please use this opportunity now that you have time to practice to ask those questions, because I'm sure that if you have a question about it, several of your other peers probably also have a similar question. So I really want this to be somewhat formal, but also somewhat informal, and just use this as a time of learning and time of discussion as we kind of all get ready to embark out there on our clinical rotation. So that is the main goal for today. So if you want to take about maybe 5 or maybe 10 minutes to work in your group and kind of talk about the patient, when we come back together, I will have some of you, we'll kind of introduce the patient, so we'll kind of go through that subjective and objective part of how you, when you're like presenting a patient, or if you're writing a SOAP note, if you're looking at the patient care process, that's either going to be the main parts of collect and assess. And then as a group, we'll talk about some of your preliminary assessments, so we'll try to make a prioritized problem list. Hopefully we can come to a consensus among all of us and sort of an agreement in how we want to approach the patient, how we want to talk about other problems, and then we'll go through each one of those with a full assessment, and then talk about a plan and kind of go from there. Does that sound good? Okay, all right, so if you guys want to take some time and talk about those things in your groups, and we'll come back together in about 10 minutes, so maybe I'll check in with you guys a little bit after 12:45 and see how you're doing. Okay? Okay, how's everybody doing so far? You need more time, or you guys are good?
What were we talking about?
I'm hearing some we're good in Athens. How about other campuses? Savannah, Albany, Augusta? You're good? Albany, that looks like your hospital water. Okay. Just checking on y'all, making sure you guys are okay. Okay. All right, so let's kind of talk about some things. Okay, so another disclaimer I forgot to mention at the beginning. So I used to teach this class session with Dr. Norton, and we would kind of like do a combo with our like substance abuse and then the rest of the clinical stuff in this case. But we changed it because I never felt like I had enough time to kind of go through the clinical stuff. So if you guys have feedback related to this specific class session that you want to give me, I would love that. This is kind of the first time y'all are like any place with this part of the case, and so it would be good to get some feedback kind of related to that. The other thing is I'm going to try to make sure that as we go through our discussion today, I didn't touch on all the questions that you guys saw in the quiz, and so that hopefully you guys will get some clarity with those too. But if I forget any, or if you have any questions related to that, just make sure you ask me before we leave, okay? All right, so I'm then going to look for a volunteer to kind of introduce this patient test, kind of go through like your beginning part of your patient presentation, so kind of giving us a brief summary of the patient, their history of their present illness, like touch on their past medical history, all that stuff. kind of go through some of the objective stuff without making an assessment of the objective stuff, and then sort of stop there. So do I have any group that bravely wants to introduce this patient to us?
No. Look at you. Where's it from? Target. Target? Yeah, that's where I got mine. I'm trying to do this without standing up.
Anyone?
Because I don't want her to be like, ah.
Stand here for an awkwardly long amount of time.
Oh my god.
Well, no one makes eye contact with me.
It's good. Yeah, I feel like sleep.
All right, Vivian Allen.
She doesn't want to stand up.
Introduce the
Stand up.
patient. This is the easy part.
I don't want to be like, ah.
Yeah, Cassidy is going to volunteer. Thank you, Cassidy. I don't usually sort of ask questions, but yeah, he'll just kind of go through all the information that you found, and then we'll kind of stop it. Okay, thank you.
So I'm just gonna like.
Okay, I'll bring you this mic so that makes it easier so you don't have to hold.
You can use this one if you want it.
Because you volunteer, we make it easy for you.
I just used it to slice it.
Okay.
If you want it.
Thank you. Okay, so Miss Natasha Bingham is a 30-year-old Caucasian female. She was found unresponsive by EMS with a respiration rate of 6 breaths per minute. She was surrounded by drug paraphernalia. Her friend did report that they were both using IV heroin. She was administered 2 milligrams of naloxone, which did increase her respiration rate temporarily. In ambulance, her blood pressure was 82/45 and her heart rate of 48. She was intubated in the emergency department when she arrived and started on dopamine. However, she did self-extubate a few hours later and did appear more agitated. She has a past medical history significant for IV drug use. However, no other medical conditions were reported. Vital signs today are blood pressure 92/45, heart rate of 46, and a respiration rate of 20. She's also febrile at 37.5 degrees Celsius, and her O2 sat to 96%. Upon physical exam, a pansystolic monitor was heard, so an echo was completed, and vegetation was seen on the tricuspid valve. She had severe tricuspid valve regurgitation as well, and a thickened mitral valve was noted. She was positive for opioids on toxicology screen as well as for ethanol. CMP did have some abnormalities. She had low sodium of 126, low chloride of 94, low V1 6, low potassium of 2.9. All other labs on the CMP were within normal limits. On her CBC, she did have a low hemoglobin of 8.8. She did have an elevated lactate of 4.3 and a low magnesium of 1.2. She did have an elevated ALT, AST of 54/35 and a low calcium of 8 as well. Several blood cultures were taken, and those susceptibility reports did come back, and that it was identified as MRSA on that blood culture. So she's not on any chrome meds, and in the hospital she is currently being administered dopamine continuous infusion, 800 milligrams per 500 ml. She's on lactated Remus continuous infusion, propofol 10 mg per ml continuous infusion, as well as Zosyn 3.375 grams per 100 milliliter every 8 hours, and enoxaparin 40 sub-Q QD for DVT prophylaxis.
Okay, does anyone have anything else they want to add or discuss that Cassidy didn't mention? Okay, so we're all good, right? I'm kind of on the same page with our patient. Okay, so what did you guys identify? So let's make our priority problems, and then we will kind of move from there. So tell me, somebody in Savannah, what did you guys identify as your primary problem?
She's got endocarditis.
We said the endocarditis. Okay. All right. Tell me in Albany, what did you guys, one of the groups in Albany, what did you guys identify as your primary problem?
We said the same thing.
Okay. Augusta, y'all have the same thing or anything different?
Same thing.
What about in Athens? Everyone same thing or anything else different? Did anyone have any other primary problems? You could have more than one potentially, or have anything different?
Oh.
I put that she had just overdosed on heroin, was addicted to heroin as her #1 problem.
Okay, so we have drug overdose as the #1 problem. Okay. So if you did it, so Griggs said alternate endocarditis is your primary problem. Did anybody, what was your second problem then? Did y'all have kind of the drug overdose as like the next thing underneath that?
Yeah, sure.
I see one or two heads nodding now.
If you can consider that a problem.
Okay. All right. So what about other campuses? Did you guys have, did you guys have your overdose situation as your second problem, or did you have it somewhere else, or you included it in something?
We included it with the endocarditis.
We had it as a second problem.
Included what?
Okay. Everyone else agree?
OB. Work up to the patient.
I think that came from Albany. Savannah and Augusta, are y'all in agreement?
I'm comfortable.
Okay. Okay. All right. Just making sure. I just wanted to make sure we're all here on the same page. Okay. All right. So first, thing to kind of situate is that you potentially. So the way I would kind of rank these problems is I sort of would put them pretty close. I would probably mark them both as primary problems, honestly, because they're both things that are life-threatening, both things that you have to address sort of immediately. I would probably, if I was going to rank them, kind of put the overdose as like maybe a step higher than my next problem with the endocarditis and all the sequelae that are associated with that, just because of the way the patient presented in the beginning. Although I know it's sort of hard because you're sort of coming in the next morning, kind of looking at this patient, and they've changed clinically from when they first presented. So I think the biggest take home here is that it's probably not super important which one you have ranking as like over the other one. It's just important that you recognize that both of these, and I think you guys all did, are immediate things that need to be addressed. If that kind of makes sense. So that's sort of how, I mean, this is pretty realistic. A lot of times when I'm coming in the next morning, you know, the patient's already presented overnight, they've kind of had some things that have happened to them, or maybe their condition has changed. So that might make you change your priority list for this day compared to the next day, but I know that that's kind of confusing. When you're looking at the patient, you have sort of like two sets of data that you're looking at. But either way, so we sort of have an overdose, unresponsive situation, and then we have this endocarditis that we have to manage primary, right? Okay. So anybody from any campus, tell me other problems that you have that you're going to address on this patient. So everything is sort of secondary, maybe, right? And then you kind of have some that are towards the bottom. So give me those.
The hypotension and low MAP.
Okay, so patient looks a little unstable, so they've got a low blood pressure and a low heart rate. Okay, what else?
She has some knee pain, so potentially infectious arthritis.
Okay, so we've got a knee pain. Okay, what else?
She has MRSA bacteremia.
Okay, MRSA bacteremia. Okay, what else?
Electrolyte abnormalities.
Okay, electrolytes. What else?
She's extubated and she's on propofol.
Okay. All right, what else?
Withdrawal symptoms.
Okay, we've got potential, I heard potential withdrawal symptoms, and then I heard some possible liver damage. Okay. What else?
Just her history of IV drug use and alcoholism.
Okay, so we've got polysubstance abuse, so with IV drug use, and we've got some alcohol use as well. Okay. What else?
I thought maybe she had some kind of anemia, like macrocytic anemia.
Okay, so we've got anemia. What else? Okay, so we've got also nicotine addiction or use. Okay. Other problems. Anything else that we haven't talked about?
I also put her toxicology workup, but
Okay, so tell me about that. So you have her toxicology workup. So how did you describe that?
I was just thinking that perhaps we should be checking for more substances, like doing an aspirin, Tylenol, urine drug screen. And since they found her unresponsive, maybe they should do a creatinine kinase level to check for abdomen.
Okay, those are all good things. Okay, so potentially looking at some other things, other potential substances of abuse. So the rest of the toxicology, aspirin, acetaminophen levels, and creatinine kinase to look for potential for abdo. Okay, all right. Other things. Knee pain. Okay.
Someone already said that.
All right. Anything else anyone wants to throw out there? Okay. All right. So down here lumped together into one problem, right? Or kind of are all or related to something else that we've identified, right? And then some of those are more standalone. So, I'm trying to think how to group these together. So which things can be grouped together? So we've got two problems that we've talked about. So, right, so we've got overdose that we talked about already, and we've got endocarditis that we talked about already. So what things live in that umbrella for those first two things that we can put there? Right, okay, so the vital sign issues, so the hemodynamic instability, so hypotension, bradycardia, that could go with which problem? All right, so I'm hearing overdose, and I think I heard somebody also say endocarditis. So could it live in both? Right, okay. All right, so we've got some things that could go in both. So then the other things that you guys have brought up too, so like the MRSA bacteremia, potentially the knee pain. I think what else you guys have brought up. So that probably lives under what problem? Endocarditis, okay. And then before we kind of talk about some of the other things, did anyone describe your second problem as anything other than just infective endocarditis? I know some of y'all did because I heard y'all talking about some of the things when I walked around, at least in Athens. Did y'all give it another name? Or did everyone just call it infective endocarditis? Go ahead. Okay, so I've heard septic arthritis, okay. What else?
I put MRSA infection.
Okay. All right. So you've got name-specific bacteria. Did anyone think the patient was septic?
No.
Like overall? Okay, I see some like maybe. I hear some maybe yes.
I
and I
looked
hear
at
some
the
definitive
stuff
yes.
for sepsis.
So tell me what you guys thought about there. So it sounds gray. So tell me what your thinking is there.
I think she only has one of the QSOFA criteria.
I personally calculated the QSO, or looked at the QSOFAs, and I gave her a score of 1, so I said it's probably not due to sepsis.
Okay. So when you did the QSOFA and you gave her a score of 1, what did you score for?
Wait, she has a score of 2.
It's that her systolic blood pressure is less than 100, and I didn't, since her respiratory rate was 20, I didn't count that, and I didn't consider her agitation to the altered mentation.
Okay, so you kind of calculated it based on her current picture. Okay. What about, did anybody else have, so those of you who said she might be septic or said yes, what did you look at there? What was your assessment there?
I also got that her QSOFA was 1, but then her like SOFA was more because she's on dopamine, and then like her lactate is high and stuff, so I didn't know which it was supposed to be, I guess.
Okay, all right, good. All right, so anybody else want to offer their thoughts?
She just said, okay, good. I thought you don't calculate.
Okay, so I'm hearing lactic acid is greater than 2, so you felt like the patient was septic? Okay, all right. Okay, so let's kind of like come out and talk about this for a second. So you have two problems here that we've talked about as like basically let's just talk about as like our co-primary problems. Like we've got a drug overdose and we've got potentially septic shock, right? So we're going to call it sepsis, it's going to be called septic shock essentially, right? Do we all agree that if we're going to call it sepsis, we would just go ahead and call it septic shock? Okay, all right, I just want to make sure we're all on the same page. Okay, so here's the deal like from a clinical situation. This is why I like to teach in this class, and it's harder for me to teach something like this in pharmacotherapy, right? In pharmacotherapy, we have to make sure we're all on the same page, and when we get to a multiple choice test question, I have to make sure that I've taught you in a way that will lead you down a path to get one right answer, right? But in real life, which you guys are about to encounter, so this is a real patient that I took care of several years ago when I first started on faculty here. When you get to real life, everything is gray, right? So best way to like test you guys and stuff is having you like write out great narratives and like assess your patient and make plans or talk to you one-on-one, kind of like you do in the practical for here, to really see and like assess your thought process, right? So in here, I like to be able to teach because it's more realistic, right? So life is gray, and you have to figure out how to operate in the gray area, especially when you start in any type of clinical practice, but especially as you start ABDs, right? So this patient is coming in, we have an infectious source, right? And then you have all these different criteria that you're supposed to be looking at, like with the SOFA score. If the score is greater than 2, then you call this patient septic, correct? So what do you do if a patient presents and they have 2 things? And so how do you know which of these SOFA criteria? So like Olivia correctly identified the patient's on a pretty significant dose of dopamine that would put her either in a SOFA score of either 3 or 4, right? So then you already have a score greater than 2. She was intubated when she first started off here, or had an airway, was intubated, she was altered, the GCS was probably pretty low when they first found her. So how do you know which of those problems or which of those assessment parameters are due to a drug overdose and which of those are due to the infection? Like, how would you know? You really have no way to delineate between the two, right? So what is the downside of saying that this patient has septic shock and starting some of those treatment interventions that we do versus saying the patient, all of the problems and all of this like hemodynamic instability and all those things that are scoring us on the SOFA are all due to a drug overdose? Like, which of those is probably more problematic? So I can hear you. So probably more problematic to say the patient wasn't septic, right? So if you go back and you remember all the things that we talked about last semester when it comes to patients with sepsis, right? Pretty significant baseline mortality rates. If we aren't prompt and quick with our interventions, then that increases our mortality rate even higher. Plus, what are those things that you're going to start when a patient is septic? What are the 2 big things that we start? Fluids and what? Antibiotics. Is that going to be harmful in this patient? And if you didn't do those things, would it be harmful? Right? So like kind of like a basic risk-benefit analysis. It's probably not super important that you really dive in and like and you're able to tell like with 100% certainty that this patient has septic shock or not, but it's probably problematic if you ignore all those interventions or those things that we do with patients with sepsis and just say, oh, this is probably all due to their drug overdose, which may very well be the case, right? So if those interventions aren't harmful, then right, you can always take the path of least harm. So does everyone kind of feel good about that? So even if this is sort of gray, I still would probably say, you know, kind of primary problems, we've got a drug overdose, and then we have septic shock secondary to infective endocarditis, and then maybe we need to lump in some of these other things that you've already talked about, right? So we've got infective endocarditis, and one of the things that can happen with that is you can get what we call septic emboli, right? Yeah, you've heard that terminology before? Right, you've got a vegetation that's on the heart valve, it's infected. So think about, you know, as your blood is pumping through your heart, it's very easy to get little pieces of that vegetation that break off. They enter the circulation and they go other places in your body, right? So you can get septic emboli almost anywhere. So it looks like in our patient's case, we have septic emboli to the lungs, correct? And then potentially it looks like septic arthritis, like I think Summer pointed out, and then I know Aaron and some other people, at least here in Athens, pointed out we had knee pain, knee swelling. I heard lots of discussion related around that. Like, could it be that she fell when she was unresponsive and that's how she hurt her knee? All of that. So all that kind of needs to be worked out, but we could just say, you know, potential septic arthritis here as well. Correct? Okay, so we feel good about those kind of 2 problems. And then the way I sort of lumped and listed the rest of my problems that you guys have identified is kind of in order after that. I put, so we have a patient who, we talked about alcohol, right? So tell me about her current alcohol status. Like, I know she's using it, and we have a patient who's like chronically using alcohol, but is there something like a more specific way just to describe her status currently?
Alcohol level 210.
Okay, all right, so Diane's telling us that our patient has an alcohol level of 210 and she is drunk. So do we agree with that? So maybe we can't make an assessment for sure about whether she's drunk or not, but we do have a patient who is acutely intoxicated with alcohol as well, in addition to other things. So I would probably lump my acute alcohol intoxication, polysubstance abuse. We kind of need to address all of those things sort of together at the same time. Is that good? Okay. And then kind of underneath that, sort of I have listed anemia, and then we have some electrolyte imbalances that we need to talk about as well. Does that kind of hit most of the high points of the things that you guys have brought up? Anything that anyone feels like I left out? that we need to talk about? Okay, all right, good. So this is kind of the framework that will drive the rest of our discussion for today. Is everyone good with that? Okay, so let's talk about our problems, and then we'll go through. And so, to me, like when we've listed our priority problems, now underneath each one, we need to sort of make an assessment. Okay, so if you've listed, like Cassie did a great job of listing all of our subjective and objective data of the patient as a whole. And so now when we get into your assessment and plan for all of these problems, like the drug or disease-related problems that we've just listed, then you make an assessment and plan. So your assessment should include those objective data with an assessment. So you kind of pull them in together. So you don't just list everything under every single problem. Like we pull in the ones that are pertinent to each of those problems. Does that make sense?
Dr. Brandon?
Yes. Okay.
Okay, so are we grouping, did you put the endocarditis under the septic shock because it's secondary? So are your main problems just this septic shock secondary to endocarditis with potential for septic arthritis? Like, is that one problem?
Yes.
Okay.
Right, so all of those together. So remember that in order to meet the definition for sepsis, you have to have an infectious source. So the nice thing here is you've got a lot of data that sort of is pointing you in one specific direction. So I would describe this problem as septic shock secondary to infective endocarditis with septic emboli to the lung and potentially to herniated wrist, so questionable septic arthritis as well. And we'll talk about that. Okay, so first let's talk about kind of the overdose due to this likely, what I've heard you guys mention is that we have an overdose situation that's due likely to her IV drug use of heroin plus the combination of her alcohol level as well, right? So somebody in Albany, walk me through your assessment, like which things of your objective data kind of pointed you in the direction to assess this problem and what your goals for treatment were.
We're talking amongst ourselves right now.
Okay. So the rest of you in your grades too, like be thinking this way. So as we go through each problem, I'm gonna ask you guys to kind of pull this in. So think about all these things. I actually filled out a little sheet myself this time to try to keep myself on track. Bless you.
Okay, so she's agitated, and there's also evidence that she was using heroin. And so as far as dealing with her withdrawal, we would need to further assess and determine what stage of withdrawal she's in, and then therefore we would treat it from there.
Okay. Savannah, what other things do you want to add to that? So what other findings that you had in your objective data would you use to assess this problem.
We agree with Albany and said that we would probably use like the COWS score or scale and figure out the withdrawal, like the amount of withdrawal the patient's having and then assess.
Okay. Augusta or Athens, what are other things that you guys have listed under this? So what about things on the vital signs do you have listed here as objective data that go into your overdose problems? Since we talked about some of these things overlap, so which things go here? Like just throw them out here and like make sure I can hear you.
I would say initially the low blood pressure, heart rate, respiratory rate.
Okay, all right, so we would list our blood pressure here, our heart rate here, your respiratory rate. What else gets listed here? The MAP, okay, yeah. Okay, so the MAP calculated from the blood pressure. Okay, what else? All right, the pulse oximetry goes here. What else?
The positive test for opiates.
Okay, all right, so you've got a toxicology screen that's positive for opiates. And how about an alcohol level goes here, right? Your alcohol level of 210 would go in this box. What else? What is like at least one thing on physical exam finding that you should list here that supports? Okay, so I heard track marks. What's the first thing? Yeah, okay, yeah. So, right, you've got some things on physical exam findings, so puncture wounds, some abrasions, things that look consistent with what we call track marks. So those are things that on physical exam would support our assessment of the patient having used IV drugs, correct? Does everyone agree? Okay. All right, so what are our treatment goals here? So I maybe wouldn't include some of this other stuff in here yet. So what are some treatment goals here?
Show us now.
Sorry, I couldn't hear you.
Yes.
All right, stabilize the patient. So how are you going to know that? So tell me what things you're looking at to stabilize your patient. So I heard something about fluid. So maybe you might put that one under sepsis. But what else? I mean, so what parameters are you specifically looking at? Right, okay, so you're going to look at your blood pressure, right? So you want to achieve an adequate MAP, so how would you define that? Probably greater than 65, right? And what else are you looking at? Okay, so you want your respiratory rate to be greater than what? Right, okay, so maybe at least greater than 12, okay? What else? Heart rate greater than 60, but you probably don't want it to be too fast, right? So maybe heart rate around 60 to 100-ish would probably be okay. All right, what else? And so what medications is this patient currently on that fit with this problem? All right, dopamine, what else? Other campuses, you guys got to chime in too. Even though I can't like physically make eyeball contact with you, I'm still looking at y'all. Or just imagine I'm looking at your eyeballs on the screen because that's what I am doing out here. All right, so we've got propofol, we've got dopamine, what else? Lactated ringers. Okay, anything else? Okay. All right, so you gave me some treatment goals, you gave me some medication. So what's your plan here for this patient? For this problem? What?
I think we need to reevaluate the patient because these blood pressure levels are kind of before they started the dopamine, so we just need to get a new blood pressure, a new MAP, new respiratory rate, all that.
Okay, all right, so get a new set of vital signs and kind of assess where you're at. And that's going to help you with your treatment, right? Specifically which drug?
The dopamine and the lactated ringers.
Okay, all right, so then your treatment goal here is to maintain normal hemodynamic status, really off pressors, off fluids, right? You want the patient to be able to maintain those things, right? So plan here is to titrate your dopamine first, right? You probably want to titrate your dopamine to achieve your goal, like blood pressure and heart rate parameters we just talked about, until you can come off on that, right? Now, Cash, whoever you up there, group in the back, what do you want to do with this patient's propofol? Are you using your mic? I'm sorry, I can't see it there.
Yeah, we're gonna
You're gonna discontinue it?
yes.
And why are you gonna discontinue it?
So they're already up and awake and they'll decrease the clinical outcomes.
Right, so she's extubated now, right? So she probably doesn't need sedation anymore because she is not on the ventilator. One of the questions when I was walking around that I got was, when patients self-extubate, that means this patient pulled their endotracheal tube out themselves. How do you know, I mean, would you ever put it back in, or can you leave them off of it? So that's a great question, and we would honestly not know the answer to that until we assess the patient. So sometimes when they self-extubate, so that's not an uncommon scenario in the situation. The patient came in pretty unresponsive, was intubated, then sort of as these things come out of their system, or we've given them things to reverse what they have used, they wake up, they're extremely agitated, sometimes they've been part of the control, we don't necessarily want to snow them with a bunch of other sedatives to make our problems worse, so they may pull the tube out themselves, but if they are staying okay, they're maintaining an adequate respiratory rate, then it's probably okay to leave them off of those things, watch and see how they do, but knowing the patient still has a bunch of things that are in their system, so you want to, again, like the things you guys have already described, you need to monitor the patient's respiratory rate, monitor their O2 stats, and see, like you may have to potentially reintubate the patient. You probably want to add some PRN, naloxone, that's on this patient's order so that it's readily available in case your patient does have issues with their respiratory status that you're able to give. So maybe that's something that I would include in my plan, is to add some PRN naloxone, maybe somewhere like 0.4 to 1 milligrams IV, and give it every 5 minutes PRN to maintain an adequate, like maybe you want their respiratory rate to be greater than 12, and then kind of go from there and see if you have to reintubate the patient, if that makes sense. Was propofol a good choice for this patient even when they weren't intubated?
No.
Probably not. Why? What's big side effects with propofol? Right, so it can cause hypotension and bradycardia, which this patient also had. So maybe it wasn't the best choice to begin with. Maybe we should have tried to pick another sedative to see if that would have been better for the patient to begin with. Okay? All right, good. So then monitoring wise, I have all the things that you guys have said. So monitoring respiratory rate, O2, saturations, monitoring blood pressure and heart rate to see if we can come down on some of these other things. Is everyone good with that? Now, that problem? Okay, so I want to make sure we don't run out of time. All right, so then let's go to the second problem. So let's talk about, this is probably the patient's most pressing problem now, that we feel like, at least for the current moment, when you've assessed your patient respiratory-wise, they look like they're okay from their drug overdose standpoint. So then this is probably the second, and then the other thing that probably is the most pressing thing to address now. So we've got septic shots. So tell me objective data that you guys have learned through. So there's a lot in this one, right? So tell me objective data that you've used in your assessment of the patient's septic shock, infective endocarditis, possible septic arthritis, all the things that we've talked about. So, just throw some out here. Okay, new murmur. All right, we've got a new murmur. What else?
Vegetation on her tricuspid valve.
Okay, we've got a vegetation on the tricuspid valve. Okay. Positive blood cultures. Just let me say heart rate. I can't hear it. But I'm still super congested from where I was last week, so I'm trying real hard to hear the things that you were saying. And read lips, which is also real hard.
How do you look at your saved
What else?
credit card?
Her vitals are also low in experienced state.
You know.
Okay, all right, so then we include some of the vital signs here too, right? So blood pressure, so your MAP and blood pressure you would include here. Heart rate you would include here because that's some of the things we're managing with some of our drug treatment. What else do you guys have listed here? So some of the things like Olivia brought up earlier I'd probably include here. So you've got a STEGA score that's greater than 2 with those combination of things that we talked about. The lactic acid, I think Diane brought up earlier, is 4.3. Patient is already currently on catheters. It looks like they've received some fluids at some point that you guys have already brought up. What else?
Her past medical history of IV drug use.
Okay, so we've got a past medical history of IV drug use, so that's going to kind of fit into our explanation and kind of why this clinical picture makes sense, right? Okay. What other things do you guys have?
I want to walk out with the car and get this.
Okay, so we've got some electrolytes, which could potentially be playing a part in here too. but I'll probably put that and address that kind of as our other problems separately, because there's sort of a lot that is going on with that, so maybe we'll talk about that in a minute. So hold on to that. What else?
How'd you get to
Neutrophils and BAMs are high.
All right, so we've got, looks like white blood cell count is within normal limits, correct? Right, but we've got a beta-anemia, right? So we've got increased band, so 12%, so we include that here. And then I think the only other things that I have listed here that you guys haven't mentioned are, so physical exam, you guys talked about the murmur. I would list the wrist and knee swelling here, and then you can also list what the patient's telling you when they wake up. And then I think sputum culture would be included here. You've got the gram stain that's back, but not the ID, or not the organism that's been ID, right?
I know mine.
And then I think we talked about everything else. So tell me kind of you've given me all of your objective data and kind of assessing it. So what's your explanation, kind of like assessing all those things together and like making sense of what this patient has? How about Augusta? Somebody there kind of tell me what you guys talked about there.
What did we talk about here? What's the question?
So here is probably where I would get into your discussion about the type of endocarditis the patient has, how you know that, why that makes sense in this patient, like criteria for like major or minor criteria when you look at endocarditis, like kind of like that type of thing.
She is right-sided infective endocarditis based on her IV drug use, and then also when they did the TEE, they determined that it was related to the right side based on the results they got with a low systolic, I believe. Hold on. They had a vegetation on the tricuspid valve measuring 0.7 times 0.7 in severe tricuspid regurgitation with right ventricular systolic pressure of 50. So that would indicate and support the right-sided as well.
Okay, good. Anybody want to add anything here? All right, so exactly. So just to reinforce what you said, we kind of expected this patient to have right-sided endocarditis, right? That makes sense with patients who are injection drug users, which I think is the more like appropriate nomenclature than IV drug abuse. Like if you look at the endocarditis guidelines. So injection drug users typically develop right-sided endocarditis. What organisms does she have? Right, to MRSA, that makes sense, right? So that's one of the most common types of organisms that we see causing endocarditis in patients who are injection drug users. Do you know why that is? Just out of curiosity. Right, yeah, so exactly. So if you think about when patients are using injection drugs, a lot of times what is contaminating the needle is skin flora. So think about normal things that live on your skin. So staph is really common, especially community-acquired, even MRSA strains that we see now. So like staph is one of the most common organisms that live on your skin. So it's very common to see that in this type of patient. So good. And then like if you think about, obviously you have echo results and blood culture positives. So all of these sort of things together are really easily to make the diagnosis for infective endocarditis. Those are your pretty major criteria for that as well. And then it would also include septic emboli to lung, and then it looks like knee and wrist as well.
Where did you get the information for the septic emboli to the lung?
So there should have been a report or a note in there of a patient with a chest x-ray. She has, was that not in there? Not in any of the notes either? Okay. So I edited this case myself, and I swear it was in there, but maybe it's not. So that was good for me to know, so I'll make sure it gets in there. But she also gives sputum culture, though, correct? No sputum culture?
It's a blood culture for it 3 times, but that was all we had for responsibility.
Maybe I'll put in 3 blood cultures and not 1 sputum culture. So, okay. But either way, it's not going to change the management of your patient. So let's just talk about septic emboli to the knee and wrist then, since you don't have all the data that I have. So, okay, so, well, that's good to know. See, I'm glad that y'all told me that, so I can make sure I fix that for next year. Okay, so either way, that's sort of all of the explanation that I have there. Is everyone good with that? Does anyone have anything they want to add or other clarification? I'm glad that y'all are asking questions. Okay, all right, so what do you want to do? Plan. Okay, somebody in here immediately said they want to give the patient bank. Does everyone agree with that? All right, good. All right, so my kinetics powerhouse is in here. What dose did you want to give her? I know you know somebody did not just tell me 15 to 20. Is that milligrams per what? Milligrams per kilo, but you got away from the patient, right? So what dose do you want to give?
I don't know. I didn't look.
Right? And John, and I know somebody's not going to tell me 30 milligrams per kilo divided 24 hours, over 24 hours divided in 1 to 2 doses because they found that in the guidelines. Because y'all are pharmacists making recommendations that people could use. So tell me what dose you want to do. So y'all got to weight in this patient, right? So somebody tell us the weight, so I'll make sure that we are at least all have the same weight.
65.9.
All right, 65.9 kilos, and then y'all calculated your creatinine clearance, correct? And what was it? Yeah, so greater than 120. So she has really good renal function for right now, at least, right? Okay. All right, so somebody give me a dose.
1 gram Q12.
Okay, we got a 1 gram Q12. What else we got?
I did 1250 Q8.
Got 1250 Q8. What else we got? 1250 Q8. Anybody have anything different?
We said 750 Q8 also.
750 Q8. Okay. Anybody else have anything different? I heard Azima talking about something else that she wanted to do different.
Oh, wow.
Oh, okay. Who cares if you're right or not? Just what do you want to do? I put 3 blood cultures in there and thought one of them was a sputum culture. So come on now.
Come on. What if I go back to this?
Okay. All right. Time out here. So Azima is saying she wants to do a loading dose and a maintenance dose. Does anybody else want to do that? Or everyone just went straight to maintenance dose?
Ooh. I got the loading dose because she's critically ill.
Okay. Anybody else? All right, so I would definitely give this patient a loading dose and then go to the maintenance dose. So then kind of what are your ranges here for what you want to do? Okay, all right, so your some 1750. Anybody have anything else?
Could you do 2 grams?
Good. All right, so I got 2, we're going to vote for 2 grams. Anybody got anything else? Okay, all right, so either way, right, so you got a loading dose. So I would definitely load this patient, right? So milligrams per kilo, loading dose, right? Anywhere from like 20 to 30, right? Milligrams per kilo. Kind of depends on where you are, different practitioners, maybe even different institutions, what they do, right? So I usually cut the difference and we'll calculate just around, I usually calculate based on 25 and then round it to a meaningful dose. So that could be really, you could go anywhere, probably if you do the calculations, it's somewhere right around either 1.75 grams. Probably, I think if you go to 1,500 milligrams, it's a little bit too low. You could go up to 2 grams, is going to be closer to like right around your 30 milligrams per kilo, right? And then in terms of your maintenance dose, it is weight-based, right? So, but I always want you guys to be in the mindset of really calculating meaningful doses, right? Physicians, providers, they will be your friend if you give them actual doses. Like, don't give them a milligram per kilo because they don't want to try to calculate that either. So it's really helpful for them if you give them, if you've already done the calculation. So maintenance dose-wise is about 15 milligrams per kilo, right? And then you kind of adjust your interval based on the patient's renal function. So I would probably definitely start this patient at Q8 interval just because the patient's renal function, she's young, she's got really good renal function, and we need, we've got a patient with a pretty significant, endocarditis, positive blood cultures. These are the types of patients we need to be pretty aggressive in our dosing with, knowing full well that we don't want to be too aggressive, right? Because then we may cause more problems down the road. But I would probably start a Q8 hour interval. So that could be anywhere from 750 to probably 1250. I think 15 milligrams is get you right around 1 gram. But you could go up or down based on that. And then what do you want to do? How do you assess that for efficacy?
I'm going to do a chalk, right, maybe 30 minutes before the fourth dose.
Okay.
For good renal function, sorry.
Okay, so Ladecia wants to get a trough level at steady state, so maybe 30 minutes before the fourth dose. And what's your goal?
15 to 20 since she's severely ill.
Okay, right, with a trough level about 15 to 20. Everyone's sort of in agreement there? Okay. What else do you want to do?
DC Zosyn.
Okay, so Morgan wants to discontinue the Zosyn. Why is that?
It's not needed.
Okay. All right, so you've got positive blood cultures. You've got a pretty good handle on what's wrong with your patient. So it's probably okay to tailor or de-escalate your antimicrobial therapy, so you can probably stop the Zosyn at this point. Is everyone good with that? Okay, what else do you want to do for this patient in your plan?
Monitor for autotoxicity and nephrotoxicity and Redman syndrome, maybe?
Okay, all right, so I want to talk about that monitoring in just 1 second, but there's probably at least 1 or 2 maybe other things that we need to talk about in our plan. So I think...
I have a question about the de-escalation.
Sure.
We kind of talked about maybe keeping on the Zosyn until you did the joint aspiration from the knee. Are we just assuming that it's the same bug in the possible septic arthritis?
Okay, that's a good question. What do you think? What's your gut feeling tell you?
Well, she was an IV drug user and she was young, so we were thinking that there could be possibilities of other bugs being there. So we kept on the Zosyn initially, but open to changing that.
Okay. So I mean, honestly, like in clinical practice, you probably could go either way. The most likely cause of her septic arthritis is going to be the same like MRSA, right? Most likely. So if you remember anything that you've ever learned about staph, especially once it gets into the bloodstream, it loves to stick to things, right? So valves, joints, like any sort of hardware you may have in place, like all of those things. So you are correct. Most likely, I mean, you could aspirate the joint and like ensure, like for sure that this is what the patient also has. That probably would not be a bad idea to do that. And because this is pretty early in the patient's clinical picture, you may have clinicians who want to keep the gram-negative coverage on for just 24 more hours to make sure nothing else pops out, which again, because this is so early in the patient's presentation, I don't think is unreasonable, but you also will find many clinicians that will go ahead and de-escalate at this point because you're unlikely to have a polymicrobial infection in this patient at this like juncture, but this could potentially go either way. Just knowing that if you continue the Zosyn, it should be in your mind that you're going to discontinue that likely within the next 24, 48 hours max, if that makes sense. Okay? So the other thing I would include here that you guys have already brought up too is, so like the dopamine, even though we're also using it in our everyday situation, also plays a role here, so including the same thing. So titrating your dopamine for your goal map until you can get that off. I know I heard some groups talking about the fluids in this patient. So this patient didn't necessarily get treated exactly probably as you would have. It didn't get the initial 30 mils per kilo bolus of fluids kind of up front. By the time you come in, there's sort of like that ship's sort of already sailed. So you're kind of like making adjustments here on the fly. So looking for those things that kind of Theo mentioned earlier. So fluid responsiveness, parameters, all that, kind of all the things that you guys sort of already know about sepsis, kind of including all that there. We talked about trough levels of monitoring. Okay, so anything else in the plan that you want to include here? Oh, go ahead. Sure. Can you, yeah, you start.
So I also had my plan to initiate norepinephrine instead of the dopamine. I need to know what you thought about that because I thought the norepinephrine was preferred.
Okay.
But besides that, didn't have nothing.
That is a great point, and I'm glad you're bringing it up. So your question. So what did you think about that? So why did you want to? So what are your thoughts? The question is about changing the dopamine to norepinephrine, like if that's okay or not. So what did you think when you were kind of? So besides that norepinephrine is preferred in the guidelines, which it is, what were some of your other thoughts that you had around that? For anyone else, did you guys think about that? this question about using norepinephrine instead of dopamine in this patient?
I thought dopamine was good to use because the patient has a low blood pressure and heart rate.
Okay. All right. So honestly, you could use either one, correct? Because which receptor activity are you looking at for the heart rate?
Beta 1.
I like sort of hear some rumbling, but I'm not. Beta 1, right? Okay, so you want beta 1 activity, right, to stimulate the heart. Your alpha activity causes your vasoconstriction to raise your blood pressure, correct? So dopamine gives you more beta 1 activity, right, compared to norepinephrine, but norepinephrine still has some beta 1 activity. Usually when you get into a little bit higher doses, then you can also support the heart rate. So it would not be wrong to have used norepinephrine in this patient up front or potentially to switch it now. But you do get a little bit more beta 1 activity with dopamine, so this is kind of the ideal patient if you were going to use dopamine to use it in, because the patient is bradycardic and hypotensive. But on the flip side, kind of what we were going to talk about when we get to monitoring, you have to be mindful of tachyarrhythmias and like kind of what I mentioned before, you want the heart rate to be greater than 60, but you also don't want it to be like 120 or 140. So if you start having issues with your heart rate is much elevated above 100, and especially if you start to have some tachyarrhythmias in the patient, then you're going to have to change that dopamine to something else, if that makes sense. Is that good? Is that good with everybody? Okay.
So I had a question about her pressors too. I guess, just looking at her vitals, her heart rate was 46 on dopamine. When would this patient be a candidate to add norepi to dopamine and like add a second pressor?
So the question, so it's going to depend a lot on how they do. So getting a new set of vital signs now would be great because also your patient is extubated. So we know also when we put patients on the ventilator with positive pressure ventilation, then that sort of can cause the blood pressure to lower too. So your patient might be fine from a blood pressure. The heart rate is always worrisome when it's less than 60, but if your patient is mentating and they have adequate perfusion, then it's okay. Some patients, live with a pretty low heart rate, especially if they're young. I mean, I'm not sure how necessarily athletically fit this patient may be, but she may run a pretty low heart rate at baseline. So now that she's sort of awake and mentating, as long as she is doing those things and she's responsive, then that's what we call asymptomatic bradycardia, if you remember that from mock code stuff. So then it would probably be fine to just leave her on dopamine. And you kind of expect as these medications wear off that she's used, that her heart rate and blood pressure will hopefully improve. If her blood pressure doesn't improve too much, then that's sort of going to make you lean towards that sort of some of the effects from her infection. Because typically we don't always see bradycardia in sepsis, right? I mean, typically you would see tachycardia as that compensatory response to maintain your cardiac output, but if that kind of makes sense. So at this point, it's probably fine to just leave her on what she's on now, kind of reassess. And then if she was still very bradycardic, I don't know that norepinephrine is really going to help because its beta 1 activity is much less than dopamine. So that's when you're going to look at more things like temporary pacing of the patient. So transcutaneous pacing or something like that as you're waiting for the rest of the stuff to wear off. But that's kind of yeah. And also more complicated in cardiology consult and all those things. So does that make sense? Okay. All right. So other things of monitoring, so we kind of talked about monitoring MAP, heart rate, looking and making sure your heart rate is high enough but not too high. And then also heard things about monitoring for bank specifically, right? So we wanted to monitor for especially nephrotoxicity, so monitoring for things like urine output, making sure the patient is still making good urine. Obviously we want to follow and trend the serum creatinine, but we know that that's going to lag behind, so the urine output is really key there. And then looking for potential red band reaction, infusion-related reactions, and then how to manage that if that occurs. Is that good? All right, does anyone have anything else they want to add to this problem? Okay.
How do you feel about her use of lactated ringers with her current electrolyte status?
How do you feel about her use of lactated ringers with her electrolyte?
Well, I did see that her lactic acid level was high, so I didn't think we should continue to use it, though I know that it doesn't elevate it much, but if it's already elevated, I would think to try to avoid that one. And then since her sodium and potassium were low, I figured we could do normal saline.
Okay.
What do you think about?
Okay. All right, so good. You're breathing at So many great teaching points. So, what do we remember about lactated ringers and elevating the lactate level?
Don't matter.
It doesn't.
It doesn't, except in what case?
Liver failure.
And right, so remember, so end-stage liver disease. So as long as your liver is functioning, even if there's a little bit of potential like hepatic damage, unless you're end-stage liver disease, your body will readily convert lactate into bicarbonate. So that should not be an issue for her. So even with the elevated lactic acid, this is a great question. So I get this all the time, like from providers in clinical practice, so that there's confusion related to that. Because when they have elevated lactate levels, you think like, well, we get. I mean, it makes sense, right? But physiologically, that shouldn't be an issue if the patient, unless they have end-stage liver disease. The other thing with lactated ringers is it's more physiologically normal, right? So there's a little bit of potassium in it. It's probably not enough to really change your potassium either in one way or the other. So you're telling me your potassium is low, which I agree with you, and so this is not going to probably make that much better, but it's definitely not going to hurt anything. It may elevate it a little bit, right? And then there is sodium content in lactated ringers, right? So it's probably fine to just keep her on lactated ringers and kind of avoid using normal saline, which then may potentially also cause problems later with increasing the chloride and then potentially causing hyperchloremic metabolic acidosis. And you've already got some other things that are sort of squeezing our kidneys right now too, so it's probably okay. I would probably just leave this patient on lactate ringers for now. Is that good? Good. Good questions and great things to bring up. Anything else? Okay. We could talk about the DVT and GI prophylaxis now, or we can talk about it later. I would will let you guys decide that. Because you can lump it under sepsis, or you can lump it later. You want to talk about it now? I've got two people that are pointing down, so I'm assuming that means now. Okay. All right, so tell me about those things. She needs it, she's on something, she needs it, she's not on something.
Depends. Faster than average people, not fast compared to like, how long does it take you to
She needs DVT prophylaxis due to the extended use of, or I guess hospital stay, and she is on enoxaparin 40 milligrams.
Okay. All right, and then what about, so I hear DVT, are we all good with, she meets criteria. For VTE prophylaxis, she's on enoxaparin 40 once a day, and we're good with the doses. Everything is fine there. Okay, what about stress ulcer prophylaxis?
Unless she's going to be re-intubated, she doesn't need it.
Okay, so I hear some discussion that she doesn't really have any major criteria and she doesn't need it. Does anyone want to vote? Anyone want to vote for it? I really influenced all of y'all in being against stress ulcer prophylaxis. Okay, so I can sort of agree right here. Okay, honestly, this could be a little bit gray in real life because she's extubated now. She wasn't started on it to begin with. She probably doesn't need it. She doesn't have any of the major risk factors. We didn't check coagulant on her when she came in. It's probably something we would check at this point, given all the other things that she has going on. It'd probably be a good idea to just check her coagulant and see where she is at baseline. Especially because she's an alcohol user and we haven't done all the things yet that we would need to kind of work up where she may be with that. So she doesn't necessarily have anything that like jumps out at me right now that's a major risk factor. There's still a pretty significant dose of vasopressors and she's septic, and so some people will sort of kind of lump that high dose of vasopressor in as potentially like a higher risk factor for stress ulcer bleeding, because you know that you're kind of like shunting blood away from the GI tract as you're sort of like trying to move everything more centrally. So potentially you could see someone wanting to add stress ulcer prophylaxis in the meantime for that reason, but I agree like that there's nothing that's kind of standing out that would make you like definitively say that you have to add it at this point. Okay. All right, so is everyone good to move on to the next problem? Okay, so let's talk about her alcohol intoxication and polysubstance abuse. So tell me things that you talked about here in your assessment.
She reports drinking 2 alcoholic drinks a day, 1 pack per day of cigarettes, and IV drug use and heroin.
Okay. All right, and probably go ahead and pull in her alcohol level here as well again, right? So the alcohol level that's reported in the EHR is 210, right? Did anyone figure out how to like interpret that in layman's terms as what everyone sort of thinks about? Yeah, so it's equivalent to 0.21. So like if you're thinking about like a lot of like before, you are probably used to like legal limit being 0.08, so you just take your level and like do the decimal 3 times. So this alcohol level is like 0.21, if that helps you kind of put that in context. Okay? What else? So what kind of things did you have here in your plan? Does she need anything added to her current regimen? Okay, so I've got a nicotine patch up here. What else?
Since she has like heroin, a history of heroin abuse, we are thinking maybe she could use some types of Suboxone, also withdrawal symptoms sometimes.
For sure.
Okay, all right, so that's like outpatient management of her heroin addiction. That's like way out of my wheelhouse. Okay, what else?
Mm-hmm.
So I heard a lot of people talking about one drug specifically, probably because it's on the quiz. So, thiamine. All right, so somebody wants to add at least thiamine. What else?
Magnesium, folic acid.
Okay, so what did, okay, is everyone kind of on the same path here? With thiamine, potentially thiamine, folic acid, potentially some other things, multivitamin, magnesium. What's that for?
To prevent Wernicke's encephalopathy, since he's an alcohol, or she's an alcoholic.
Okay, so tell me about that. What is that? Does everyone know, has everyone heard those words before at some point? Oh, I'm sorry. Okay, so Teresa said the patient needs to be at least on thiamine and some other things to prevent Wernicke's encephalopathy because she's at risk for this with her alcohol use. Yes, we've heard these words. No, we have not. We know something about thiamine and alcohol use. I feel like I heard some people talking about, I know that you were supposed to use thiamine and alcohol, but I don't remember why. Anyone? Okay, well good. Well, this is why we're here, to all get on the same path. Okay, so you guys over here, tell me about what Wernicke's encephalopathy is and what the worry is and what the risk for.
So thiamine is needed in the mitochondria in the brain for energy and to like build new cells and stuff. And when you are drinking a lot of alcohol and not intaking as much thiamine, because the only place we get it is from our diet, you can cause encephalopathy in the brain from that lack of thiamine.
Okay, and is it reversible or irreversible, or you didn't find that?
I think it's irreversible once it's happened. So we do the thiamine to prevent it from happening in the first place.
Right. Okay. So who's heard of an antibiotic? Like a lot of people. Okay. All right. So, and you know why it gets a name, but antibiotic, like why it gets its name?
Yellow.
Because it's yellow. Why is it yellow? It's not the thiamine. Yeah, so IV multivitamin, which is on back order right now, which we cannot get for a long time, so now our antibiotics are white. But the yellow color comes from injectable multivitamin, which is yellow in color. So that's where like the name comes from, even though like you're not supposed to use it because it's not a specific concoction like where you go from place to place. But what you'll hear is people talking about antibiotics. So when patients chronically use alcohol, but actually can be any patient who is malnourished for any reason. So and like keep that in mind. So like Morgan said, so thiamine is something that comes from our diet. It's the only place that we get it. And you need thiamine for all the things that she just mentioned. So you guys can hear that, right? On mic, okay, good. All right, so in patients who use alcohol, they're at risk, or any patient who's nutritionally depleted for whatever reason, they're at risk for Wernicke's encephalopathy, and it is an irreversible condition. So if you look in the literature about it, I think it's like undiagnosed and still about 80% of patients, so it's pretty high risk. And so thiamine, remember, is vitamin B what? B1, right? So it's water-soluble vitamin. So thinking about risk-benefit, it is not harmful to give patients that come in with an alcohol history thiamine, right? To give them too much, they will just pee it out. But your downside complications could be potentially devastating. So patients, especially who come in with a pretty significant substance abuse history, will oftentimes get thiamine. Doses can range, especially once you have sort of made the diagnosis the patient has chronic use encephalopathy, then you use much higher doses of thiamine for longer periods of time. But something to keep in mind is that when these patients present, we should be screening and looking to make sure that they get at least of about 100 milligrams of thiamine. Usually, we also go ahead and give them folic acid. We tend to always also try to put magnesium in there. As you can see, like in this patient, it's really common for patients to present with hypomagnesemia as well. But it is something to sort of keep in mind, kind of recognize like that thiamine has an association there with patients who chronically use alcohol. Good? From there? Okay. Let me see what else I have here. Okay, so other things too, this problem is kind of a little bit complex too because you've got an acute situation and you've got something that you sort of have to keep in mind. So right now your patient's acutely intoxicated, so they're probably not going to withdraw from at least alcohol yet. But as their alcohol levels normalize, if this patient is truly a chronic user and if they use more than about, probably if they use more than 2 drinks per day, then as she's self-reported, then you're going to have to monitor the patients for potential for alcohol withdrawal. Usually it happens around day 3, but depending on how much they use and how long they've used, you can get withdrawal symptoms when patients still have alcohol in their system. So just because they have alcohol that's still in their system doesn't mean that they're not at risk for withdrawal. So really looking and being mindful of patients. So looking for those signs and symptoms of withdrawal and then potentially using some of those other things that you guys have learned about with withdrawal assessment and making interventions there, like potentially the benzos and that type of thing. And then all the other stuff. So nicotine patch could potentially be used. We do use it a good bit on the inpatient side. I personally have mixed feelings about it. There are some smaller data that suggest that there could be potential risk for cardiac issues, like with increased risk of MI potentially. It's hard to know if that's like specifically from using nicotine replacement. It also tends to cause, it can cause like bad dreams in patients. So in the ICU, sometimes we will hold off on it at least initially, but as the patient kind of stabilizes and she's extubated and talking now and looking like she may eventually go to the floor in the next couple of days. So that might be something to consider as well. So definitely you'll see nicotine patches used pretty routinely though in clinical practice. And then getting her set up with all those like assessments, like was she ready to quit, like with all of her polysubstance abuse, counseling, all those things definitely need to be done with this patient before they leave sort of more towards closer to discharge. Is everyone good with that?
Dr. Brandon?
Yes.
So we talked about the banana bag. Is that what a CIWA protocol?
So CIWA is that Clinical Institute for Withdrawal Assessment. So that's a score based on asking the patients, basically if they're having any sort of like visual, auditory or tactile hallucinations, if they have any of the other signs and symptoms, like if they're tremulous or have increased heart rate or increased temperatures. And based on all those things, you score. And based on what your score is, it will give you an associated like amount of lorazepam, for example, to give the patient to try to manage their withdrawal symptoms. So they're separate. So the withdrawal assessment, basically, a lot of times, like in institutions, they're all put together in the same order set. So you'll have like your thiamine, folic acid, like IV infusion with all of your withdrawal stuff, because again, it's so important to make sure you don't miss the thiamine, so that it's all there together. But the CIWA stuff that you learn is like symptom-triggered treatment of withdrawal. So it's like separate from the other stuff. Good question. Anything else anybody wants to add here? All right, so what about anemia? So these are a little bit quicker because these are our kind of problems to look at. So what's her hemoglobin? 8.8 a year. All right, and so did you guys discuss that as a patient being anemic? Okay, and so do we need to do anything about that for this patient?
Like celery.
What kind of plan do we have?
Strawberries and stuff.
Hey, it works. Yeah. Why not? Do you go to grocery stores here?
I thought that since she had the high MCV, that it was macrocytic anemia, and so she should get checked for her B12 and folate levels.
Okay. All right. Okay, so she potentially needs some workup for her anemia to figure out if she's potentially deficient. So other things, because this is like sort of a pharmacy thing and sort of not, but it's something to be mindful of. So remember in the ICU, our hemoglobin threshold of concern is less than 7. So remembering like what our normal values of hemoglobin is, that's pretty low. So we sort of know that in the ICU and critical illness setting, patients tend to predominantly run pretty low hemoglobin levels. So unless they're actively bleeding or have an acute like myocardial ischemia, then we will allow hemoglobins to be as low as 7 before we'll transfuse cracked red blood cells to try to bring them up. And then I agree with what Bonnie's saying. If the patient is chronically anemic or continues to have issues with anemia, especially as she is more clinically stable, then we would need to send the iron studies, B12, and kind of evaluate that. So for right now, our main thing is just to monitor that and make sure that's not going any lower. So really, that is probably all I would say there. We were only going to transfuse if the hemoglobin becomes less than 7 or if she starts actively bleeding. Everyone good with that? Okay, and then lastly, let's talk about some electrolyte imbalances. So what are all the, so I heard magnesium earlier, I heard potassium earlier. What other things do you guys want to add?
No.
We get free stuff every month.
You get one free thing a month. You get like a sandwich or a dinner or $5 off a person.
I heard somebody say the calcium was low earlier, but is it low?
No.
Why not?
Like the calcium, not.
All right, so we corrected it, right, for her low albumin, and then we found that her calcium was in the normal range. Is that correct? Is that what I'm hearing? Okay, good. So then our potassium and magnesium are only 2 that we need to address? And sodium, what is the sodium again? I forget. 126. Okay, so potentially need to address her sodium levels. We probably need to see if she is chronically low or if that's an acutely low situation. Sodium will probably resolve as we give her fluids. But hopefully that will come out. So what do you want to do for her potassium and magnesium? What's the risk that you're worried about with these 2 being low? So she probably won't have a STEMI from this, but she may have some other things. So arrhythmias, right? So remember potassium when too low or too high can induce arrhythmias. And we already have a patient who's got sort of an irritated heart because she's got a valve that's got a vegetation on it. So she's also got a couple of risk factors here for having some arrhythmias. And we have our own medication that also can induce arrhythmias here. So we've got a lot of things going on with her. So optimizing her potassium and magnesium would probably be prudent, right? So which one do you replace first? All right, so I would say replace her magnesium and either replace her potassium with the magnesium or replace it right after you've given, replace potassium after you've given magnesium. We won't get into dosing of that because that's not something that I think is super important for you right now. But just knowing that we're going to try to keep the level of potassium around 4, magnesium around 2 to try to prevent some arrhythmias. Is that good? Okay. I do have one more thing that I want to talk about before you guys run off. But are there any other questions or problems or things that I haven't addressed adequately yet? Or other questions that you guys have? Okay. The only other thing with this case the other reason why I like to use this case is I want you guys to start thinking this way as you guys get into clinical rotations. But what are your thoughts about a patient who is an IV drug user? I forgot to talk about this. In endocarditis, how long does she need treatment for? 6 weeks. And does it need to be IV or PO? It needs to be IV. And you have a patient who is an IV drug user. So what are your thoughts on managing that? Can you send this patient home with a PICC line and set them up with home health? Why not?
Should have heroin.
Okay, so a couple of different things here that need to come into play. So, what's her payer status? She have insurance? No, doesn't sound like she has insurance, right? So, do you think home health is going to be an option for her? What about outpatient infusion centers? Do you think they want to take her as a patient? Now, okay, so the other thing you guys are bringing up is the ethical question here, right? How do you feel about sending a patient home with a PICC line, which is a sterilely placed IV line, and a patient who may, depending on when you have a conversation with her, continue to use heroin as an outpatient? So that's an ethical dilemma that needs to be answered by the team, right, that's taking care of this patient. There actually are some data that show that sending a patient out with a line does not necessarily increase or really change their IV drug use, but I will tell you from an ethical situation, providers are going to be very uncomfortable with being the physician that signs off on that, right, because that's just that's a challenging position to be in, right, as a provider. So I can tell you, just like from having been on both sides of the coin, so in previous times of when I first started practicing, before we had some of the longer acting, like IV anti-MRSA drugs, we had to keep these patients in the hospital for 6 weeks and treat them inpatient for 6 weeks. Which you can imagine is not make most health systems super excited because that's a huge cost burden on society in general. But you also couldn't send the patient anywhere, and it's not ethical to send the patient out with inadequate treatment, right? So it's kind of the thing that we were faced with. Now we have newer drugs, so things like dalbavancin that are longer acting anti-MRSA drugs that are not FDA approved for endocarditis, right? Good, real randomized controlled trials showing this. We do have some case reports, some anecdotal evidence to show potential effectiveness. So that's something that can be considered for these patients if you're sort of up against the wall. And then, the question comes about if oral therapy is appropriate for this patient, and probably not. We probably don't have a lot of data that would really support sending this patient out with oral therapy. I can tell you what we did for this patient. So I would definitely consult ID in this, as this patient gets ready to go. You need a whole team of people to look at this patient as a whole and figure out a plan with her. So what we did was we gave her, we typically don't get this started in the ICU. I know I'm super bad about telling y'all I don't care about a lot of the stuff that goes on. I'm all worried about what's happening in the ICU, and then we sort of let somebody else deal with that later. But when these patients come in these situations, we know that this is going to be an issue, so we need to start having these conversations pretty early in developing a plan. So we actually set this patient up. We gave her 1 dose of dalbavancin before she was to leave. And then they had arranged it with the hospital administrator. She was going to come into our outpatient infusion center. They basically were just going to eat the cost of that to have her come back in a week later and get another dose of dalbavancin. Remember, that's once weekly that you can use. There's some case reports to support that. So she got her 1 dose and she left. The other thing about these patients is you can't make them stay, and there are not many patients who are going to be super excited about staying in your hospital for 6 weeks either. And they will be against medical advice. They can sign papers and say that they accept the risk of knowing that they may die and leave. So that is the other thing that you kind of have to balance too, and just saying you're just going to be here for 6 weeks and you have to suck it up. So she left, and then she did not follow up a week later. So she never came back and came and got her dose a week later. So that's kind of an unfortunate situation that you may face in practice. But I just want you guys to start thinking about, we teach you ideal situations, this is the way of practice according to the guidelines, and then kind of when you get out into the real world, as you guys know, things can be messy sometimes, and you have to think through what the best thing is for the patient and kind of make decisions from there. But just kind of get you guys to think about some of these other social things that may come up outside of offering the most optimal therapy, but when you have to kind of make changes based on other factors. So I don't have anything else for you guys today. If you have any questions, I would love to answer them. Otherwise, I really appreciate all of your engagement and interaction with our case today. If you have any feedback for things I can improve, and I will try to fix the things that were not right, then I would love to hear that as well. So thanks, guys. Enjoy the rest of your week. I think this is the last time I teach y'all, in the big class. We're getting so close to being done. Yeah.